Good evening, everyone, and thank you for joining us for tonight's International Dermatology Foundation Educational Series webinar. The title of our program tonight is A Single Treatment Option for Patients with Psoriatic Disease or Hidradenitis Suppurativa. As moderator this evening, we have Dr. Ali Shabazz, Clinical Assistant Professor, Texas A&M School of Medicine, Dermatologist, Westlake Dermatology, and Cosmetic Surgery. As speaker, we have Dr. Jeffrey Crowley, Bakersfield Dermatology and Skin Cancer Medical Group in Bakersfield, California. We would like to thank our supporter for making this educational event possible, and tonight that is UCB. Before we begin, a few logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues, please submit your questions in the question pane on the right-hand side of your screen. And at the end of this webinar, a survey will pop up in your browser and will also be emailed to you within 1 to 2 days. We would greatly appreciate it if you could fill out this short survey. And finally, also within 1 to 2 days of the webinar, a certificate of attendance will be emailed to you. We will have a Q&A portion of tonight's program, so at the end of the program, make sure that you have submitted your questions using the question pane on the right-hand side of your screen. Now, without further ado, I would like to pass the floor virtually to Dr. Shabazz.
Good evening, everyone, and thank you, Ashley, for that introduction. My name is Ali Shabazz. I'm a dermatologist here in Austin, Texas, and a clinical assistant professor at Texas A&M School of Medicine. It is my pleasure to be invited today to moderate with Dr. Jeff Crowley, and I'd also like to thank Dr. Leon Kircik for inviting me to moderate this webinar. A little bit about the International Dermatology Foundation. Its principal mission is to raise awareness and improve dermatological care all over the world, especially in underserviced areas through education. As you can see, next slide, we've been fortunate to have world-class leaders in dermatology invited in our previous educational sessions. And if you'd like to stay up to date with the IDF Educational Series webinars, please follow us on Instagram, LinkedIn, or Facebook at the following handles. You can also please visit us at www.idfeducationalseries.com to register for upcoming educational events. And without further ado, it's my pleasure to introduce Dr. Jeffrey Crowley, who is a dermatologist in Bakersfield Dermatology and Skin Cancer Medical Group in Bakersfield, California, to discuss a single treatment option for patients with psoriatic disease or hidradenitis suppurativa. Thank you.
Awesome. Thank you, Dr. Shabazz. It's my pleasure to be here and to talk a little bit about BIMZELX. And it's kind of fun because we're going to be able to talk about 3 different diseases in one talk tonight. And this is BIMZELX, a single treatment option for patients with, I went one past, sorry about that. Get back in sync here. A single treatment option for patients with psoriatic disease or HFS. And it's really important to point out that this is, BIMZELX is different than other IL-17s. It is an IL-17A and IL-17F inhibitor. And we're going to talk a little bit about what that means and why IL-17F is important in all 3 of the disease states that we're going to talk about tonight. This is a promotional program sponsored by UCB, and the speaker has been compensated for this presentation and this educational information. So we're going to talk about challenges of treating inflammatory skin diseases, the role of IL-17A and IL-17F in the both adaptive and the innate immune system, key BIMZELX efficacy and safety data, and then we'll talk about BIMZELX dosing and support. So gaps exist in inflammatory skin disease care. And what does this really mean? It means it's really hard to have every aspect of a drug possible for our patients. Let's say we have a patient with psoriasis and psoriatic arthritis. We want a drug that's going to work for both of the disease conditions, and sometimes that's not achievable with one agent. And we may have to try a few different things to get there. So that's one of the gaps. The other gap is just accepting that the fact that psoriatic disease is an inflammatory systemic disease. And that we really do need to offer our patients systemic control when their disease is beyond just some small plaques on the skin that they can handle with topical therapies. And I really think that is And another key factor is really giving our patients options to control their disease with the systemic therapy. Lots of things to weigh when we're choosing treatments and we're proposing treatments with our patients. Some things on the right-hand side, you'll see durability, efficacy in psoriasis, and convenient dosing. These are things that we think about maybe more on the IL-23 aspect, with dosing being every 2 or 3 months, some good psoriasis efficacy, and some nice long-lasting durability. And on the other side, we have some of the things we might think about more as IL-17 kind of characteristics. Rapidity, really a fast onset. Efficacy in psoriatic arthritis, that's high level and includes axial disease, and also works well in HS. IL-23s don't work well in HS, and IL-17s have become kind of the mainstay of HS therapy after TNFs. And so these are kind of things we have to balance. And one of the things that BIMZELX can do, as you'll see when we go through this, is it can offer kind of all of these. Rapid onset, with probably the fastest drug that I know of, and in these disease conditions. High efficacy in psoriatic arthritis, works in HS. Durable responses. We're going to show you some long-term data in multiple disease conditions. Efficacy in psoriasis, and then convenient dosing. In psoriasis, it's every 8 weeks after those upfront doses for the first 16 weeks. So every 8 weeks is pretty convenient. It really kind of gets into the realm of what we see with the IL-23 agents. And so when you're thinking about a therapy, are you leaving some of these aspects on the table when you're choosing one drug over another? So psoriasis and psoriatic arthritis treatment should target the highest level of disease control. And what does that mean? It means with psoriasis, we want patients to have clear skin, when possible. And that really is the goal in my clinic, is to get the patient as clear as possible. And it's not always going to be achievable, but it's something that we should aim for. And if the patient still has residual disease that's impacting them, they should be given the option to maybe try something that may be able to get them to higher levels of control. And with psoriatic arthritis, it means controlling the inflammation. And if you control the inflammation, you're then going to be able to prevent radiographic progression. So if you still have swollen and tender joints, you still have progression of disease. You still have inflammation that's leading to bony erosions and other things, changes that may be irreversible. And so certainly we want to get patients as good as possible. Now with psoriatic arthritis, that's often hard if the patient has long-standing disease, because there may be stuff that, even with blocking inflammation completely, they may still have some residual issues that can lead to pain and functional loss. So 3 diseases: psoriasis, psoriatic arthritis, HS, one clear pathway, okay? So IL-17A and IL-17F are important in all 3 of these diseases, both in the innate immune pathways, and those are the pathways that are kind of present in normal skin, as well as actively inflamed skin, normal joints, etc. And this is kind of the innate pathway that's kind of sitting there the whole time. And this is what is triggered. And as it triggers, it amplifies. And then once that signal amplification starts, it really activates the adaptive immune pathway. And the adaptive immune pathway is just kind of throwing fuel on the fire. And that's where it really takes off. And that is IL-23 dependent, whereas the innate immune system is IL-23 independent. We'll talk a little bit more about that. So this is the adaptive pathway, IL-23 dependent. This is the typical kind of pathway we think about with psoriasis, where we have myeloid antigen-presenting cells that are activated by IL-23. Those then that lead to active lymphocytes, the Th17 cells, which produce the effector cytokines, IL-17A, IL-17F, as well as some others. And that is important in the inflammatory process. But there also is the innate pathway, and this is kind of working in the background of patients who inherit the tendency to have these diseases. And these innate lymphocytes, these mucosal itinerant T cells and the gamma delta T cells are kind of regulatory cells that are in the skin and other tissues as well. And these also lead to IL-17A and IL-17F formation. So when you put those both together, the innate and the adaptive immune system, we get the inflammation that's occurring. So if you're just targeting IL-23, you're not blocking IL-17A and IL-17F to the same extent as if you're targeting those cytokines on their own. And this inflammation is important in all three of our diseases. It's important in the skin, in psoriasis, in the joints, in psoriatic arthritis, and these inflammatory lesions of hidradenitis suppurativa. And it also mentions here that IL-17A and IL-17F also contribute to the pathogenesis of ankylosing spondylitis and non-radiographic axial spondyloarthritis. And this is important because this is an aspect of psoriatic arthritis that we often really don't have great control, and that's axial disease. That's the stuff that leads to the stiffness, to fatigue, these other issues, which are really important to get a handle on our patients, and often the hardest part to really control. And so we really want to make sure that we're addressing that. And here we know we have proof that this works in these axial diseases. And if you take that as a proxy for axial psoriatic arthritis, then we are showing that we can get good efficacy here by blocking IL-17A and IL-17F. So IL-17A and F play critical roles in psoriatic disease. And this is really interesting. So this is actually showing in psoriasis, okay, we have patients with non-lesional skin and patients with lesional skin. So these are biopsies, and they're showing the levels, the expression levels of IL-17A and IL-17F. So IL-17A is on the left-hand side. We see lesional skin has about a 6.7-fold increase over non-lesional skin. And IL-17F has an 8-fold increase of lesional over non-lesional skin. Now, this is the same y-axis that we're looking at. So you see there is a lot more IL-17F around than there is IL-17A. And in fact, it's about 30 to 50 times higher than IL-17A in tissues that are inflamed, such as psoriatic lesions in the synovium and also lesions of hidradenitis suppurativa. So IL-17F is just present in a lot more volume than IL-17A. Now, there's a caveat there. IL-17F isn't quite as biologically active as IL-17A, but if you're just blocking IL-17A, you're leaving a lot of inflammation on the table. So BIMZELX inhibits multiple pathways of inflammation and blocks IL-17A and IL-17F dimers. Now, there are 3 things that can be blocked: IL-17AA homodimer, IL-17FF homodimer, and the IL-17AF heterodimer. And BIMZELX blocks all 3 of these. IL-17A inhibitors just block 2 of the 3. And then the receptor antagonist blocks both IL-17A and IL-17F, but in a different way. So BIMZELX is unique in the way that it can block all 3 of these inflammatory cytokines. And there we are, the 3 inflammatory cytokines being handled by BIMZELX. So 5 indications for immune-mediated inflammatory diseases, all approved in about 1 year. So very active year for UCB. Psoriasis, adults with moderate severe plaque psoriasis, psoriatic arthritis, active psoriatic arthritis, HS, adults with HS, ankylosing spondylitis, so that axial disease, and the non-radiographic axial spondyloarthritis. So all of those are the indications currently for BIMZELX. So a broad panoply of diseases with varying levels of varying tissues that are inflamed. BIMZELX is the #1 fastest growing interleukin in the IL-17 and IL-23 classes, with more than 100,000 patients treated worldwide. So we have a broad spectrum of clinical trials that have been done, 150,000 total patient years of exposure across indications in those trials, and no new safety signals at 5 years in psoriasis. So we know what the safety issues are. We're going to talk about those at some length today, but we know what they are. We know how to manage those. Achieving higher benchmark outcomes may improve patients' chances of having meaningful symptom relief. And so BIMZELX is able to push the envelope. With psoriasis, the primary endpoints were PASI 90, and PASI 100 in the phase 3b trial against secukinumab. In psoriatic arthritis, ACR 50. So usually it's an ACR 20 response, move to an ACR 50. And in HS, it's the high score 75, not the high score 50, which was key secondary endpoint here. And so it's nice to have higher bars, but you have to have a drug that actually achieves those higher bars of efficacy. And as you'll see, across all three of these diseases, BIMZELX achieves high levels of efficacy control at these benchmarks that are much higher than what we've seen in traditional studies. So single treatment off, kind of checking the boxes. Rapid onset of efficacy, again, among the fastest out there. Sustained responses, skin and joint efficacy in psoriatic disease, symptom relief beyond that high score 50, which is what has been the standard bar that's been looked at over time. And then convenient dosing with the psoriasis, every 8-week dosing, which is kind of approaching what some of the IL-23 inhibitors can achieve. So we can be able to get intermittent dosing and still maintain high levels of efficacy, which is critical. So in psoriasis, I'm not going to go through all these trials, but just so you know that BIMZELX has proven superior to TNF inhibitor, adalimumab, ustekinumab, IL-12/23 inhibitor, and secukinumab, IL-17A inhibitor. So there was a head-to-head trial with secukinumab and BIMZELX, and BIMZELX had higher, statistically significant higher PASI 100 rates compared to secukinumab. And of course, these all had comparisons to placebo as well. And we're going to be looking at some pooled data, which takes advantage of the number of patients that are in this trial to give a little stronger data when we go through these efficacy points. So skin clearance was seen from the first dose. So one dose, 4 weeks later, you get the second dose. Before that second dose, at week 4, PASI 75, 77%. Almost half had a PASI 90, and 1 in 5 patients had a PASI 100. This is real. I see this with my patients. Some patients call and they're just amazed at what they've been able to achieve with a single dose. It's great buy-in for a patient. I think it really does encourage them to hold the course and really try to get their skin as clear as possible. And this is a key beneficial aspect of this drug. And this is an actual patient, week 0 to week 4. So they're not completely clear at week 4, but the erythema has dropped down dramatically. Induration is a little harder to see on the slide, but these plaques have thinned dramatically, and the scaling certainly is down as well. And then as we go out to week 16, they do become a PASI 100 respond. So after those initial doses every 4 weeks, they do achieve a PASI 100. And it's more than half of patients that get PASI 100. Okay? So week 16, in fact, it's up to 68% of patients achieve a PASI 100 at week 16 across all of the studies. This is non-responder imputation, so this is solid numbers. There's no way to, patients dropping out of the study are not impacting this result. High numbers achieve PASI 100. And most patients are completely clear for up to 5 years. We're going to show that data. Long-term data is important, and long-term data is always derived a little different way depending on how the studies were run. And in this case, we had data out to 4 years, and we'll talk about the 5th year in a moment. And we have all the patients who were PASI 90 responders at 1 year are included in this analysis, okay? So it's a look back on those patients, and it's a look forward on those patients over time. So at year 1, we have close to 100% PASI 90 responders. And out at year 4, 3 years later, we have 88% that are still PASI 90. 85% of patients start out at year 1 as a PASI 100, and it's 73% still at a PASI 100 out 3 years later. This is a modified NRI analysis, so this is a good way of looking at long-term data. Patients are dropping out because they're worsening of psoriasis or having side effects from the drug attributed to drug. They're considered non-responders. And then there was an additional group of patients that stayed in between year 4 and year 5. And those patients, 77% of them achieved PASI 100 at year 5. So we actually have data on some patients going out 5 years here. I do think that this reflects what I see in clinic is patients stay, and this is the standard dosing. This is the 8-week dosing, the approved dosing in the US. So patients are able to maintain these levels of control with a shot every 8 weeks after those first 16 weeks. Some actual photos, week 0, week 2. So just look at how much that erythema has faded in 2 weeks. That's after a single dose. And these are real patients. So now let's move on to psoriatic arthritis. So we have control of psoriasis at high levels. How do we do with psoriatic arthritis? Well, there were 2 trials. There was the BIOPTIMA trial, which was the bio-naive trial, and there was the BE-COMPLETE trial, which is for patients who have been up to 2 previous TNF agents and not had adequate control. So TNF, inadequate responders. And why is it important to have both populations? Because there's a lot of cycling through of TNFs. And so we want to make sure that any new mechanism that we reach for, such as IL-17A/F inhibition, is going to control that inflammation on those patients who didn't have success with anti-TNF agents. Also remember that with psoriatic arthritis trials, patients are on background disease-modifying antiemetic drugs, such as methotrexate. Some patients are even on stable doses of steroids. So what as a dermatologist, what I really like getting out of these studies, besides seeing that the efficacy is good, is looking at the safety and making sure that the agent that I'm adding on to whatever the background mix of things are, some of which are immunosuppressive like methotrexate, isn't going to influence safety issues. So it's the first biologic in psoriatic arthritis to measure that ACR50 at week 16 as the primary endpoint. ACR50 much more stringent than ACR20. You have to have both a 50% improvement in tender joint count and swollen joint count, and an improvement of 3 of the 5 of the other ACR criteria. Global assessment of disease activity by the patient, by the physician, assessment of pain, the health-related questionnaire disability index, which asks things like, can you button your shirt? Can you do things around your house? You know, what your normal activities are? Are they impaired by your disease? And lastly, it's a blood test. It's an acute phase reactant, CRP or ESR. So both tender and swollen joint count have to improve 50%, and you have to have 3 of 5 of the others. So it is a high bar. And one reason you know it's a high bar is because when you look at ACR 50 results, the placebo numbers are much smaller than they are with ACR 20. So 4 weeks, okay, 16% ACR 50 in BE-COMPLETE, 18% in BE-OPTIMAL, low placebo numbers. You go out to week 16, we have 43 and 44% at that ACR 50 response respectively. And again, relatively low placebo numbers. When you're looking at ACR 20, sometimes you're seeing placebo numbers, 20, 25, 30%. So this is a level of disease control, which in general requires a potent drug to be able to achieve. And we also want to prevent the progression of irreversible joint damage. I want to make clear that in the label with BIMZELX, it does have that it has been proven to prevent the progression, radiographic progression of disease. And 84% of patients experience no radiographic progression through 2 years of therapy. And this is important. Not all drugs have this in their label and the ability to claim this. And I do think it is important to be able to have this aspect for good disease control. Complete resolution of dactylitis in 3/4 of patients, and half of patients had complete resolution of enthesitis. So if you don't know what dactylitis is, that swollen finger or toe sausage digit, okay? It's kind of a hallmark of psoriatic arthritis, almost pathognomonic of the disease. And then the Achilles enthesitis, the Achilles tendonitis, that's also quite a hallmark of inflammatory psoriatic arthritis. And 50% had complete resolution of enthesitis. Enthesitis is the inflammation of where a tendon or ligament insert into bone, okay? So enthesitis is also really important in the back, in the axial disease, as well as things like elbows and knees and ankles. So the joint improvement was sustained through 3 years. This is looking at the ACR 50 response through 3 years. This is a non-responder imputation. So a patient drops out of the trial for whatever reason, they move away, they're in a car crash, whatever, they're considered a non-responder. And the fact that numbers are going up means patients are getting better. There's no way of hiding anything in this kind of data. All right, so joint improvement was sustained through 3 years in Be Complete, and both Be Complete and Be Optimal had very similar results, even though the patients who had been on previous TNFs are probably a little bit tougher to treat. But it's nice to see the repeatability of these two trials in a very different patient population. And lastly, probably my favorite slide of the ACR is real patient impact on disability, work impairment, healthcare costs. These are things that are really important to patients. If they can actually function again and get control of their life. All right, now we're going to move on to hidradenitis suppurativa, and this is looking beyond high score 50 in HS. The BEHEARD 1 and 2 trials were the basis of the approval of BIMZELX in hidradenitis suppurativa. And rapid results were observed in the very first dose in HS. And this is important with HS. HS is a disease where there's just basically a forest fire. It is, by the time patients usually come in and see us, get the diagnosis, they often have multiple areas of involvement, very inflamed lesions, drainage, etc. And we have, this biofilm that gets into these draining tunnels. It's kind of like a rabbit warren under the skin. And so there is just such a plethora of inflammation going on, and you really need to shut that down. With every drug that we've ever looked at with HS, and I've been a part of a lot of the trials, you need higher doses. TNF need twice the dose you need in psoriasis. With IL-17A, you need more than the dose for psoriasis. And here, we're using literally twice the dose that's used in psoriasis. So these patients are dosed every 2 weeks for the first 16 weeks, and then every 4 weeks with the 320 milligrams. And that's what you need. You need to shut this disease down. And at week 2, we see that 22% of patients achieve a high score 50 response, 40% out at week 4, and then almost 60% out at week 16 have that high score 50 response. And then, we really want this to work in the long run, and we've been disappointed with HS treatments in the past where, they work up front and then they just kind of wear off. They stop working. And I think anyone who's treated HS much has seen this effect. And what's really nice here, again, this is all modified NRI. This is through almost 3 years of analysis. And what you're seeing is over time, this is somewhat enriched population because patients are staying in the trial generally doing a little bit better. But the patients stay in at pretty high numbers. We have 77% high score 50. So that sounds great. But what really is important there, of that 77%, 70% of them high score 75, 50% are high score 90, and 41% are high score 100. So even though we're not just getting high score 50 responses, we're getting 75, 90, 100% improvement. So 4 out of 10 patients are getting their inflammation completely under control. Out at 3 years. And this is something that we don't see with the other drugs. We can see some good control, but we don't see these deeper, more durable levels of control that can be achieved with BIMZELX. Consistent safety profile. So here we have the short-term safety data in psoriasis and psoriatic arthritis, okay? And what do you see really teasing out here? Candidal infections. You've heard about them. You heard about this drug, you've heard about that. That's a little under 10% of patients in 16 weeks have candidal infection. That's vast majority are oral candidiasis, not so much vulvovaginal candidiasis or others, but it's oral candidiasis. And so I tell all of my patients about this. And I think the rate is at least this in the real world population. We don't have quite as clean a population as the psoriasis population. A lot of diabetes that may not be adequately managed, et cetera, which can make you more likely to get candidal infection. So I tell my patients about this. Most patients have one, and you treat that, and they don't have a second one. But some patients do have multiple candidal infections, and in my opinion, I think it's reasonable to do some prophylaxis for some of these patients that have more than one candidal infection. At least for a while, and then maybe be able to back off that over time. But this is one of the things you need to know about. If you look at the psoriatic arthritis patients, not quite as much candidiasis. And now they do have a little bit lower dosing up front, and that may be part of the reason of that. Then what else are we seeing? Some liver enzyme elevations, but that's also seen in placebo. We'll talk a little bit more about that. Serious infections are quite low across the board, which is great to see. Adjudicated IBD. So there have been some new onset inflammatory bowel disease, just like with every other IL-17 inhibitor. So that's something you want to talk about, ask about symptoms, signs, history of inflammatory bowel disease. And we'll talk a little bit more about suicidal ideation behavior and hypersensitivity reactions as we go through the rest of the safety data. So short-term safety data in HS. And what are we seeing here? Serious infections, very low. Remember, we're using double the dose that we do in psoriasis, and we're not seeing, serious infections of any rate. Fungal infections, about the same rate as we see with psoriasis, even though they're getting twice as much drug. And then some of the other issues as we go down the line. One thing, the hypersensitivity reaction with the HS, that includes dermatitis and eczema. So there is this eczematous reaction that we see with HS sometimes. Sometimes it's in areas where there's drainage. So if you see enough HS patients, you will see this on patients with BIMZELX where they get a little bit of eczema. This can be treated with typical things we treat eczema with either some topical steroids or some non-steroidal alternatives to control it. So it's not a game changer, but it's something that you will see if you see enough of these patients on drug. And then long-term safety data. And what I like here is we have the psoriatic arthritis data and the psoriasis data. So we can really see if BIMZELX added to things like methotrexate and steroids is really causing any issues. And if you look at the serious infection rates across the board, they're right within the range of what we would expect to see in the background population of these patients. So let's delve into some of the nitty-gritty of, again, here's the HS long-term data, out to 3 years safety data with an HS drug, and with a pretty high number of patients evaluated out there for 3 years. And we're not seeing anything increasing over time, which is nice to see. And now we're going to talk about some of the other verbiage in the package insert. And one of them, there was an increased rate of passive suicidal ideation by questionnaire in the psoriasis trials and in the HS trials, but not in the psoriatic arthritis trials. There was the 3 suicide attempts in psoriasis and 1 suicide attempt in psoriatic arthritis and 2 in HS. And almost all of these patients had background underlying mental health conditions. And there was the 1 completed suicide in the psoriasis patient without a previous psychiatric history, and that was after being on the drug for over 700 days. And so what there is a little bit of increase in passive suicidalization by questionnaire. The numbers are shown there, so that's what there is. What there is not is really a risk for patients in terms of suicide attempts or completed suicides versus the background rates, and we'll talk about background rates in a moment. And this important statement here, a causal association between treatment with BIMZELX and increased risk of suicidal ideation and behavior has not been definitively established, okay? And so that's important. We really don't have any reason here. Remember, patients with HS are getting twice as much drug. We're not seeing any kind of dose-dependent effect here at all. And let's put all of this into context of what we see with other drugs. And I think that's really important. And so there was this nice study, which will show up here, looking at different agents and suicidal ideation and behavior. As you see BIMZELX there at 0.13, The anti-IL-17As are about the same. The one outlier here is the anti-IL-17 receptor, that's brodalumab, a little bit higher, but still within the range of what we would see in the background population. And then the anti-IL-23s, right in the range of what we're seeing with BIMZELX. So you can scan those QR codes if you want to see links to those papers. But I think this really does put it into context. And what I tell patients is if, we're gonna put you on this drug, you'll see that there's a warning for suicidal ideation behavior. We haven't seen any increased risk really of suicides or anything like that, but we know that a lot of patients have underlying mental health issues, and we want you to be aware of that. And if you're on an antidepressant or something like that, and you're working with your therapist, let them know that you're taking this drug, and we'll keep an eye on you as well. But I do like to talk about it because they might hear about it third hand rather than hear about it from me. Next up is some liver enzymes. So, pretty similar to placebo, but there are a few more patients with HS with 5 times upper limit of normal of AST and ALT abnormalities. And then in psoriasis, this is what we see, okay? So remember, we have comparator studies with 3 different comparators in the BIMZELX portfolio. And so we're able to see placebo is a little bit lower than BIMZELX for having liver enzyme abnormalities. This is 3 times upper limit of normal. Adalimumab is higher than BIMZELX. Secukinumab is higher than BIMZELX. And ustekinumab is about the same as BIMZELX. So even though there's a warning to check liver up front and periodically thereafter on BIMZELX, we're not really seeing any differential from what we see with other drugs, okay? So I do check liver enzymes up front. I do check again, usually at about 3-month time frame. And then I'm kind of done with checking labs unless there's something else going on with the patient at that point. So what labs do you need for this drug? You do need to check for TB prior to starting. So I do that. I get a hepatic panel, which includes ALK, phos, bilirubin, ALT, and AST. And I get a comprehensive metabolic panel, and I get a CBC as well. And so that's my baseline labs for BIMZELX. And then I'll check the hepatic panel again, usually about 3 months into therapy. But most of this is just background disease noise. And this is just the rest of the ISI. We talked about SIB, we talked about infections with candidiasis being the primary one, but we're not seeing increased risk of serious infections. Checking for TB prior to starting drug. We do know, though, that IL-23s and IL-17s don't really play a significant role in reactivation of tuberculosis, and we don't see issues there in general, but it is part of the package insert. All right, there we go. Liver enzyme abnormalities, we talked about inflammatory bowel disease, some new onset disease can occur. Immunizations, avoid live vaccines, and the most common adverse reactions are listed there. And of course, like any medication for that's an injectable drug, you can see some hypersensitivity reactions as well. Dosing access and support. Got to be able to get the drug for our patients. So consistent dosing with psoriasis, psoriatic arthritis, and HS, and convenient dosing. All right, so here we have the psoriasis dosing with the 5 initiation doses, week 0, 4, 8, 12, and 16, and then every 8 weeks thereafter. If the patient has predominantly psoriatic arthritis and not much psoriasis, you may inherit these patients if they're seen by a rheumatologist. They're going to be just dosed with monthly dosing from the every 4-week dosing from the beginning and carried through, but half of the dose. So the 320 is the 160. Okay, and with psoriasis, they get 320 milligrams. And with HS, it's every 2 weeks, the 320 milligrams every 2 weeks for the first 16 weeks, and then every 4 weeks thereafter. And it does come both in 160 and a 320 milligram injection. So the 320 milligram injection is takes a little bit longer to give. So it's about 15 full seconds. So patients should be aware of that if they're going to be getting that auto injector. So best in class access in IL-17s for psoriasis, 90% commercially insured patients are covered. There's a great program to get drug to patients if there is an issue with the insurance, and they can certainly go on that bridge program for quite a while. And HS is a little tougher. Sometimes there could be step edits for being on a previous TNF. So sometimes you might have to try a TNF first. Sometimes there can be step edits for IL-17A inhibitor as well, such as secukinumab. So you may have to try those first, see how they work, and if they're not getting adequate control, then you can move on to BIMZELX. Some allow BIMZELX as first-line therapy. So rapid access to be able to get, navigate that bridge, $5 or $15, depending on whether it's covered or not, and a single point of contact with nurse navigators that can help with things. It takes some of the burden off of your busy practices. So what do you get with BIMZELX? You get a single treatment option that really drives high levels of efficacy in psoriasis, with 68% having PASI 100 response at 16 weeks on average in the trials. Psoriatic arthritis with an ACR 50 achievable in over 40%, almost 50% of patients over time, and with HS being able to drive higher levels of efficacy with high scores 75, 90, and 100 out over a 3-year period. Consistent safety we can manage and handle, just things you need to be aware of, we've discussed tonight. And convenient dosing. I mean, we really can get a dosing that's every 8 weeks in psoriasis, every 4 weeks in HS and psoriatic arthritis. That is really convenient to our patients. And sustained and durable responses, drug that's going to work for the long haul. And that brings you up to the thank you slide, and I think we have some time for some questions.
Thank you, Dr. Crowley. That was fantastic. We have had lots of questions come in. I have a question for you from one of our attendees. The question is, how do you frame the expected timeline of improvement for patients starting IL-17 AF therapy, especially regarding itch, scaling, and visible clearance?
Yeah, so that's a great question. And I think part of it is framing it on where the patient's been in the past. If they've been on a previous biologic, I'll ask them about what their experience was with that, and say, a single dose of this drug is going to, clear about 50% of your disease burden in a month, and maybe even a little bit more. And that's what I tell them. And I tell them, not only is their skin going to get better and their scaling going to get better, but their itch and skin pain is going to improve dramatically. And we didn't show that data here, but there is good data for improvement in itch and skin pain in patients with psoriasis. There's good data with pain improvement in patients with HS, which is, as you know, is one of the big factors we have with hidradenitis.
Right,
and there's good data with psoriatic arthritis as well.
Great, thank you. Another question here is, how do you weigh durability data from control trials versus real-world experience when setting treatment expectations? And how do we convey this to patients?
Yeah, so there's a lot to that question,
Mm-hmm.
Because it's difficult to interpret all these different trials. So, when we have a clinical trial, we have long-term data. We know that data is pretty strong because those patients are being seen regularly, right? And we know we know the numbers of patients that are left over a certain period of time. So we can kind of get an idea of what the real durability is. But real durability in the free range population is different, right? You have patients with uncontrolled diabetes, you have patients with other issues. So registry data can give you some of that, but that's still a little bit of an artificial narrative because we still have, the patient has to come in and want to be in a registry. And then we have claims data. And the claims data probably is the best way to look at patients, how well they stay on therapy over time. Those data are a little different in terms of what you see up front and what you see over time, depending on the different agents. And BIMZELX performs very well in these, but so do IL-23 agents for psoriasis, for instance. So you can see some good durability there. I think that you got to kind of put it all together. I certainly like to see the clinical trial data because that's the most rigorous and the most most viewed. But I like to see the fact that in a real world population, this drug is behaving over time, right? And some drugs do not. You can get drop-offs of 50, 70% on some drugs after the first year. And if that's happening, that's probably not going to be a drug that's going to work well for a lot of your patients over time. So I think you want a drug that's going to maintain high levels over time.
I think that's a great point. I often use claims data as an artificial proxy to see how well our patients are doing in the real world. I think trials are trials and they're fantastic. We need that kind of raw data, but at the same time, trials are not real world. So I think when we can see that mimicked and mirrored in real world efficacy, when we have our patients in daily clinical practice, it really just is the perfect marriage, right? When they mirror both perfectly well. Time for one more question, if that's okay. The last question is, what strategies do you use to support adherence and persistence over time, particularly as patient symptoms improve and then follow-up intervals lengthen?
Yeah, this is probably the biggest problem we have in clinic, and I'm sure in the last week you've had a patient who comes in and is not on their drug anymore, right? And why? Whether is it a systemic failure? Did they change insurance? Did they just not call back the insurance when there was some issue? Did they stop a delivery for whatever reason? Were they sick and they thought they shouldn't take it because they're not feeling well? All of these things can lead to problems with adherence. I think you gotta kind of get the gist of where your patient's coming from. Some patients are just so good and they're just going to be so consistent, and you're not going to have trouble with them. Other patients I will see back more frequently just because of this issue, right? Or because they've had a history of this happening in the past, where they've been on a drug, kind of went off it, went back on it, weren't able to maintain control. So I'll keep a little tighter check on those patients, and I think that's important. There's a lot of work that's been done on things like reminders to have your injections and things like that, but I really think they really haven't played out in being able to be used easily in our practices. But it is something that I think is important. Try to get patients to stay on these drugs long term, because if you stop a drug and your disease flares up and you go back on it, you're less likely to get that patient back to where they were before. And that's regardless of the agent, and we have data to show that. You don't recapture everyone. And I tell patients that, I tell them, even though you're doing really well and you're completely clear, you still need to be on this drug to be able to maintain that clearance over time. And I think that's important for them to know. And backing out, the tendency is to want to back off on dosing and not take your shot when you need to. And, patients do that all the time. But, they're coming back in and they're seeing a little bit of flare of their drug, and you think that's the reason. I think a gentle nudge to try to stay a little bit more on top of it can be helpful.
And I think you bring a great point. First and foremost, I think using the first appointment as a way to say, hey, recapture rates are going to be low if we go off this drug, so we want to stay on it. That hopefully education sets a great foundation. At the same time, we know some of these diseases, specifically HS, they wobble, right? They come and go, up and down. And so if you don't have adherence, despite going through a flare, patients are going to fall off and be lost to follow-up. So I think you're right. The foundation of education, but trying to keep them on routine follow-ups is so key. And with busy workflows and clinics, it's hard to do that, but we all need to find a way to make them efficient.
HS really is different. And because that background fluctuation could be so dramatic. And, I didn't realize how much this was the case until I started doing studies with HS back, 15 years ago, and seeing a patient and screening them and then seeing them 2 weeks later to start them on drug. And they were like a different patient, sometimes worse, sometimes better. Completely different. And so you can imagine what it's like to have that disease and not know what your skin is going to be doing from day to day, just the psychological terror that has to be. And so, patients need to know their background disease is still going to fluctuate even on therapy.
And I think sometimes it feels like, you're hand-holding, but that hand-holding and close following is so important to keep them on drug early on, because eventually we can modulate the disease ideally, right? The longer they stay on the medication. Okay. I think sorry.
All right, very good. Yeah. No, just one other thing with HS is don't stop whatever you're using when you're starting BIMZELX. So if the patient's on some hormone topicals, of doing some low dose oral antibiotics, keep that on. Don't take it away when you start a new drug.
And we've seen that in the trials as well, right? Those background systemic conventional therapies just are adjuncts, but they're great supportive therapies to our novel biologics. Absolutely.
Absolutely.
Okay. Sorry, I can't ask any more questions, but please submit your questions on the right-hand side, or if you have any additional questions, please email us at info@idef educationalseries.com, and we will follow up accordingly. I think that's all the time we have for today. Thank you, Dr. Crowley, and thank you to UCB for sponsoring this webinar. We appreciate the support on Educational Foundation. And if there is no more, thank you guys. Have a good night. Bye-bye.